failure to get the last opening of the chest tube inside the chest wall. يعني ده الشيست تيوب يا جماعه فيها كام اوبننج عشان تو فاسيليتيت بريلي. مرات بتلاقي واحده زي دي الاوبننج اوتسايد ده so that the underwater seed will continue to bubble and you cannot diagnose this unless you do الشيست اكس-راي. مش كده؟ معناها جزء من التيوب يا اما initially it was not introduced لحد ما تخش اللاست opening في الكافيتي ومرات مع حركه المريض it may get out so the tube will continue to bubble. او مرات تبدا البابل وقف لكن تظهر عليك بعد شويه. وظهر بعد شويه معناها either في connection او التيوب طلعت شويه من السايد بتاعها. مرات حتى الانتري اوف ذا تيوب مرات السيرجن بيعمل او الدوس بيكون الانسيدنت وايد يكون في سي الاير بيخش من outside so it causes popping. This is probably may also be caused by intraparenchymal tube flexing. وده احنا طبعا we have seen this practically in this hospital. You know, sometimes well, it happens everywhere in which was in this hospital. They introduce the tube inside the lung parenchyma not in the pleural cavity. So if the tube is inside the lung parenchyma, it will continue to bubble also, and it will not swim. واخر حاجه طبعا يا جماعه is the bronchopleural system. هو communication between the airway or the alveolar level with the pleural cavity. This is bronchopleural fistula. الآن نفتكر دكتور طارق الآن indication with the bronchopleural fistula continuously bubbling all through. The definition بتاعي يا جماعة is the pathological communication between the bronchial tree and the pleural space. It may occur at the main stem, lower bronchus or segmental. طبعا كل ما يا جماعة كل ما كانت الكوميونيكيشن في حتة distant it has the chance to heal مش كده؟ يعني at the alveolar level it probably will heal. لكن لو كان main bronchus معناها probably will not مش كده؟ طيب الكوزز دي you can read about it online there are many causes لكن common cause we see in the ICU لما يكون عندك بتاع thoracic surgery is the lung resection. طبعا this is a very wide topic مش كده؟ اللي هو types of fistula post lung surgery بيقسموها ل early و late and كده. احنا في الاي سي يو barotrauma is one of the causes of the bronchopleural fistula and usually it's at the alveolar level. عشان كده it has better chance to heal. Clinically, it may be best described as a resistant air leak or a failure to re-inflate the lung despite chest drainage for more than any bubbling continued for more than 24 hours. It is a bronchopleural fistula. Usually, you do chest X-ray. You take a hydropneumothorax. This is a bronchopleural fistula. A CT scan also. And this is the defect fistula. And the lung will never expand as long as it is in the bronchopleural fistula. This is another bronchopleural fistula at the level of the main bronchus fistula. This is the carina. At the level of the main bronchus. You can do also bronchoscopy to locate the site of the. When you do the bronchoscope, the maximum is the subsegmental. It includes subsegmental orifice, and you cannot reduce the bronchoscope further than this. And you will never see alveolar bronchopleural pleural fistula. You will not reach the alveoli by the bronchoscope. عشان كده sometimes you do what's called bronchography. You inject dye في الحته اللي انت متوقع فيها leak, and this will go to the pleural cavity. Now this is bronchoscopy showing this fistula opening. Yeah? This is bronchoscopy also showing this is the carina. You can diagnose this is the fistula. زي ما قلت you can do also bronchography. These facilities in other hospitals. In other you inject methylene too, and it will be shown in the pleural cavity. Right. It's called selective, selective bronchography. أنا يا جماعة في حاجة غريبة والله. Enjoyment of practicing medicine is when you have all the facilities. And this is part of the self-satisfaction والله. لكن زي ما قالت شاهد قبل شوية لو ما عندك بوتاسيوم وعندك you get depressed والله في النهاية كده. أول حاجة you feel guilty towards the patient مش كده. And this is very bad feeling والله. أول ما تحس إنك أنت you are not doing your job in the proper way and you are guilty أنت ما اديتش البيشنت حقك. This will be reflected in your mood مش كده. لكن لما تلقى all the facilities this is part of the enjoyment of practicing medicine. إنك أنت تلقى أي حاجة أنت you want to. لكن المفروض يكونوا depressed والله كله. So this is the size of the. I think you can read it from there. Very good. So we will escape the for the sake of the time. المانجمنت برضه في ميديكال مانجمنت وفي bronchoscopic management وفي surgical management. And if you think it is because of the infection, you give antibiotics or anti-TB, and patient بتاع طارق يفتكر عنده TB عنده persistent problem exposed bronchopleural fistula. And أهم حاجة يا جماعة في الchronic bronchopleural fistula is the nutritional supplement also. You have to give them nutritional supplement. طيب. Then I will escape all this عشان these are the bronchoscopic methods of closing the fistula. If all these fail, then you go for surgical. You always involve the surgeons, prosthetic surgeons, in the management of the bronchopleural fistula. ممكن يا دكتور بعدين تستعينوا بدينا. طيب نجي احنا بالنسبه لنا هو الفنتليتر مانجمنت اوف ذا bronchopleural fistula. طيب the patient with bronchopleural fistula, the ventilator should be adjusted to minimize both tidal volume and plateau pressure. يمكن ده الناس اللي هم عندهم براكتس في الاي سي this is what they have to do. Thereby minimizing alveolar inflation and the transpulmonary pressure gradient respectively. So what you do in the ventilator, you reduce the tidal volume and by this you reduce the plateau pressure, and sometimes you go for permissive hypercapnia. Reduce the number of reduce the number of the full ventilator delivered pressures. يعني allow the patient to have spontaneous breathing. يا جماعة spontaneous breathing within the ventilator is a negative pressure ventilation. عشان كده it will less causing leak of the air. يعني as long as you can allow the patient to breathe spontaneously, this will heal the bronchopleural fistula. Increase the tidal volume of each ventilated delivered breath. Set high inspiratory flow. Minimize beat. If you increase the beat, the flow will increase. Right. Come on, if you will extubate, that is the last target. Mostly, لأنه يا جماعة الفنتليتر will help the bronchopleural fistula to persist. If you extubate them, they have a better chance for healing of the bronchopleural fistula. في experimental therapies الدكتور بعدين يتكلم عنها في البرزنتيشن. You can do independent lung ventilation, jet ventilation, test tube occlusion during inspiration. There are a lot of trials. طيب نيجي للنقطه الثانيه اللي هو البيشنت ترانسبورت. If you want to transport patient in underwater drainage system to مثلا dialysis or to radiological department. طيب لو هو على suction you have to stop the suction and you have to disconnect and left an opening على suction open to air. لو قفلتها you're going to cause pneumothorax, tension pneumothorax. So leave it open. الحاجة الثانية don't clamp the tube. الناس طبعا they clamp and clamp. This is serious والله. Serious خاصة if the tube is if the underwater tube is open. Should never, and then ensure the chamber is below the patient chest level during transport. ما تحط عليه في السرير. طيب في example يا جماعة very easy. عندك two options. في الاندر seat system دي فيها فتحة from which you can introduce the needle and you take the fluid. وطبعا دي سهلة اللي هو ال 3 piece 1 unit. لو ما عندك فيها you can create a loop. loop زي ما قلنا اللوب ده احنا ما عايزينه. You create a loop and then you introduce a needle and you take. Don't disconnect the system. لأنه كل ما يجي disconnect the system there is a risk of injection والله. So don't disconnect عشان تاخذ الفلويد. Either by needle أو by where you can take the fluid from the 3 piece 1 unit. لما تاخذ الديبند روت you use a very small needle يا جماعه. You have also to apply alcohol. In loop there you apply alcohol and then you use the multi-gauge needle and you take the sample. لكن don't disconnect the system as what's happening here. تلقى الناس فتحت disconnected وخلت الفلويد سترونج. طيب في وحدات بيكون عندهم فتحه تحت so you can take that. لكن دي اللي هي this is where you can take the fluid في 3 piece 1 unit اللي هي الفتحه دي. لكن هو نازل تاخذ منه without opening the system and without damaging them and without creating a loop. كده يا جماعه السيستم ده is very good system والله. طيب suction versus no suction وده طبعا هو رابط كونترافيرسي. انتم كلكم مريتوا بانه انا ما اعرف والله يمكن ما عندكم suction هنا لكن this is a controversial issue. Not all patients require suction of course. Suction is required when air or fluid needs a greater pressure gradient to move from the pleural space to the conducting system. If you want to have more negative pressure, then you apply suction. Indications: the use of suction helps overcome an air leak in non-resolved pneumothorax by improving the rate of air flow out of the patient. Pneumothorax, a lung did not expand. You apply negative pressure, it will help to expand the lung. عادة اللنج يا جماعة بيكون عندها pathology. يعني if you have a healthy visceral pleura and you drain the air, the lung will expand immediately والله. لكن لو زول كان عنده previous infection أو lung fibrosis, it will not expand immediately. It needs more negative pressure to allow the lung to expand. And healthy lungs in pneumothorax, they expand immediately. There is no evidence to support its routine use in initial treatment of spontaneous. يعني ما أي زول spontaneous pneumothorax يقول suction. This is not allowed. Suction في chemical fluoridesis. We need suction في chemical fluoridesis. طيب. أنا ذكرت يمكن في البرونكوبلورال فيستولا suction is controversial and then probably you attend the topic بتاع management of bronchoscopy. Some authors they recommend suction, or some they are against suction. The controversial issue. طيب يا جماعه السكشن زي ما قلنا المره اللي فاتت لو ما عندك safe chamber you cannot apply suction. طيب how much suction you apply depends on the level of the water in the tank. الليفل ده ما بيحدد how much suction is. لو زدت المويه هنا you are applying more suction. لو نقصت التيكت you are applying lower suction. How do you know anything you apply the appropriate suction? By gentle bubbling of the underwater system. أول لو البابل ده كان شديد معناه you are applying more pressure. And this will probably damage the lung. This should be a gentle bubbling. The lung is not. And you control this by the pressure drop. And negative pressure. لو عملت gentle bubbling معناه you are doing the appropriate suction, which will not damage the lung parenchyma. معناه عندك bubbling هنا في underwater sea if there is air leak, وعندك bubbling gentle bubbling because you are applying negative pressure in the pleural cavity. الماكسيمم يا جماعه usually 20 centimeter. This goes to the suction. ده هنا draining blood or fluid. هنا الاندر sea 2 centimeter below the level of the underwater sea, and this is for the suction, and this is the atmospheric sea. This should be left open. By adding or removing water in the suction control chamber, the chest drain effectively controls the amount of suction involved on the pleural cavity. البابلينج طبعا this will continue, لأن you are the one who created this bubbling by applying negative pressure. طيب. It is the height of water, not the setting of the suction source, that actually limits the amount of suction transmitted to the pleural cavity. ما بيعتمد على how much pressure you do that. It depends on the level of the water. So you will with how much suction you have applied to the system. طيب. The suction يا جماعة usual is minus 20 centimeter of water اللي هو equal to 14.7 ولا 15 millimeter of mercury. Hello? Hello? طيب يا جماعة في برضه نقطة والله ما عندنا مشكلة. You can apply suction either by the standard high volume, high pressure suction units or a low central suction. In both conditions, you have to have a regulator. In both conditions, you have to have a regulator. You can set the below pressure, you increase gradually, and you observe the third chamber. لحد ما يجيب هذا البوبلينج معناها that is the pressure needed to drain whatever in the pleural cavity. Hello? أنا بس في المحاضرة والله. ونفتكر الكلام ده قلناه المرة اللي فاتت. Chest drain must not be connected directly to the high negative pressure without control adapter. Otherwise, you will suction the lung parenchyma وتلقاها هتكفي في التيوب. وأنا have seen this والله. إنه lung parenchyma يقول لك في تيشو طلعت. This is the lung parenchyma. If you don't control the pressure, I have seen this in this sector. Lung parenchyma drained in the pleural, in the chest tube. Right. طبعا الوتر يا جماعه في الثيرد chamber اللي هو suction chamber واللي evaporate. عشان كده كل مره if you want to stick to 20 centimeter you have to make sure دائما انها تكون you can add water to make sure that you are applying the same suction all through. طيب نيجي complications of chest tube insertion. هي الري expansion بالنسبه and malposition chest tube والinfection. أنا will not talk about infection والله لأنه if you disconnect the system frequently you will get infection. And sometimes the infection gets entry from the entry site. And I will talk about the re-expansion pulmonary edema لأنه I have seen cases in re-expansion pulmonary edema. طيب re-expansion pulmonary edema usually occurs unilaterally. طبعا الفكرة اللي فيها المنطلق ولا دون الفيوجن. After rapid re-expansion of a collapsed lung in patients with يعني زول عنده collapsed lung انت you drain the fluid ولا الاير a lung will expand rapidly and it will cause what's called re-expansion pulmonary. فهي unilateral pulmonary. ماذا يقدر pulmonary edema? This is bilateral. If you drain pneumothorax rapidly, you will get a re-expansion pulmonary edema. If you drain large amount of pleural fluid, more than 1.5 or 1 liter, you will get a re-expansion pulmonary edema. Or if you remove an obstructing endobronchial tumor. Sometimes يا جماعة عندك tumor obstructing the lung, it causes lung collapse, مش كده؟ And then by whatever procedure you remove this obstruction rapidly, the lung will re-expand and cause re-expansion pulmonary edema. So it's an endobronchial tumor. So if you apply fast rate of drain in case of pleural effusion and pneumothorax, you will get a re-expansion pulmonary edema. This is not uncommon complication in the mouth. Now this patient has a pneumothorax. This is the last one. So this is the pneumothorax. This is all air, nothing vascular marking data. And this is the pleural line. طبعا we talk about pneumothorax in sections of Now this is 3 hours after chest tube insertion. You get a unilateral, but this is the chest tube. This chest tube. And this is the re-expansion pulmonary unilateral. Typically, patients have had symptoms of pneumothorax for several days, usually 3 or more days. Patients typically present soon after the inciting event, usually within an hour. I mean, draining whatever in the pleural cavity. Yeah? Like it can go to up to, in some cases, up to 24 hours. This is how they present. Symptoms are persistent cough generally for more than 20 minutes and regardless of the presence of breathing. Usually they get persistent cough. Then you suspect re-expansion pulmonary edema. The cardinal symptoms and signs are tachypnea, tachycardia, and freckles on the affected side of the lung, as well as hypoxemia, which may be refractory to oxygen therapy. Some of them will need mechanical ventilator because of the re-expansion pulmonary edema. The clinical course varies from isolated radiographic change to complete cardiopulmonary collapse. Now, how does this occur? They think a collapsed blood vessels. If you rapidly relieve the collapse, the fluid will leak into the lung interstitial. It's a theory. The edema may progress for 24 to 48 hours and persist for 4 to 5 days. So it's self-limiting, you know. If you are able to support the patient during the 3-4 days, then they will recover completely. And sometimes, as we said, you may need to put them on a mechanical ventilator. So this is the re-expansion pulmonary edema with the chest tube. This is left-sided pulmonary edema, re-expansion pulmonary edema, and this is the chest. لو شفت X-ray زي كده, you can easily say that this is re-expansion pulmonary. في other causes طبعا, I think this is most likely cause. And this is how the re-expansion pulmonary edema is seen on the CT scan. Ground glass appearance. This is re-expansion pulmonary edema, and this is re-expansion pulmonary edema. Despite being treated, mortality may up to 20%. High mortality. And it is only when pneumothorax or a pleural effusion, you drain it because mortality. If you don't guard against. Right. Treatment is supportive, mainly consisting of supplemental oxygen and necessary mechanical ventilation. The disease is usually self-limited. But lateral defibrillations on the affected side is recommended, which in unilateral cases contributes to reducing the pulmonary shunt and improving oxygenation. So you put the patient on the affected side, lateral defibrillations. This is the least that you can do if you don't have a ventilatory support. No? Non-invasive ventilation should be considered. You give them beep if if you put them on a ventilator. This will resolve the prevention, or this is the important issue, real prevention. Gradual drainage of large flow diffusion or pneumothorax is the key method for prevention. So this is one of the iatrogenic causes you treat it by prevention. Right. For draining pleural diffusion, you have two options. As usual, البريش society guidelines recommend a maximum of 1. يعني لو عندك زول عنده 5 liters you drain 1.5 liter at the immediately. غالبا عشان to normalize the mediastinum and relieve the pressure on the other lung. And once you have a huge pleural effusion, you will lose the lung function on the affected side, and if you have mediastinal shift, you will cause pressure on the contralateral lung, so that is also compromised. So immediately what you do, you drain 1.5 liter, 1.5 fluid that will be drained in the first occasion, and immediately during management of malignant pleural. Usually it's a malignant pleural effusion which create a problem. It becomes very massive effusion causing mediastinal shift. So at once you drain 1.5 liter. Any remaining fluid should be drained 1.5 liter at a time at 2-hour interval. يعني بعد كده كل ساعتين بتطلع لك 1.5 liter. This is 1.5 liter, and then every 2 hours you control the drainage. أنا بس في المحاضرة ولا بخلص وبرجع. طيب. واضح يا جماعة؟ Initially 1.5 liter and then 1.5 liter every 2 hours. طيب السكند اوبينيون اللي هو الامريكان اللي هو 1.5 لتر immediately and then 500 per hour. هم قريبات من بعض so they are not very different. عشان to guard against re-expansion pulmonary edema. زي ما قلنا if you have an X-ray like this, the massive right pleural effusion deviating the mediastinum to the left side and compromising the function of that. أصلاً الرايت lung here lost function. It becomes collapsed. And then you have to drain لحد ما to normalize the trachea. Usually 1.5 liter will shift the mediastinum to the center, and then you gradually drain the fluid. In case of pneumothorax, I'll drain it slow by an underwater sea. أنا أوريكم what happens practically. Surgeons لما يحطوا underwater لما يحطوا الchest tube, they allow the air to come immediately without connecting that. Then what you do, you insert the chest tube, you clamp it for a second لحد ما توصل underwater sea. لأنه underwater sea will slow the level of drainage of the pneumothorax and it will guard against a re-expansion pulmonary edema. So essentially they like to see the air patterns, and this will cause they will drain the air rapidly, and this will cause a expansion of the pulmonary edema. Right. This is the last part of the lecture. The malnutrition is very important. And this is not uncommon in the practice everywhere. انك انت you put the tube in the wrong position. And commonest is the intraparenchymal. We have seen this one in this hospital. Not one occasion, many occasions. Extrathoracic, mediastinal locations in the tissues and intra-abdominal. Sometimes in the liver and sometimes in the spleen. It can go to the heart actually. طيب. طيب انت لو دخلتها it will not function طبعا لو دخلتها في area outside the pleural cavity. It will never swim. It will bubble in only one condition اللي هو if you are intraparenchymal. الباقيات it will never bubble. ما في حته ثانيه فيها air. It will increase طبعا mobility and mortality. So the tube will be non-functioning, non-swinging, and non-bubbling except in the intraparenchymal insertion of the chest tube. This will cause persistent bubbling. طيب the diagnosis of bad position chest tube is not by chest X-ray والله. The X-ray will not know. Never. The only way to diagnose bad position is by doing a CT scan. CT scan, it will show you. The middle intraparenchymal usually it occurs لو في previous dural adhesions أو previous lung disease. طيب في مرات this is happens والله إنه if there is pneumothorax on the right side they put the chest tube on the left side. This happens in practice. فمرات بيحطوا التيوب in the healthy side. And the worst scenario in that you end with a bronchopleural fistula if you penetrate the lung parenchyma. And sometimes you can cause hemorrhage, bleeding from the pulmonary vessels. No? ده نتكلم على intraparenchyma. Clue to the diagnosis and any liquid range of لو انت خدت مثلا chest tube for pneumothorax and no air came out. It will bubble في pneumothorax وفي لكن لو خدتها في pleural effusion and no fluid came out معناها it's in the wrong position. So it will inadequate range of air and fluid, persistent bubbling and no swelling. دي معناها intraparenchyma. قلنا chest X-ray will not show لكن he will show by the CT scan. Unusually لما a tube goes through the lung parenchyma, it will cause a hematoma around the tube. I think the opacity around the tube. This is because of the bleeding. Now this is a CT, this is an X-ray. حتى لو بتقول الإكس-راي دي بتقول إنه we don't know whether it's intraparenchyma. لكن this is the CT scan. It showed that the tube is intra. The lung, this collapsed lung there. And this is the tube. So this is an intraparenchymal chest tube. This is clearly intraparenchymal chest tube. And this is the pneumothorax. This is intra. بدل ما يدخل الchest tube هنا دخلها intraparenchymal. عندها طبعا في subcutaneous edema وفي pneumothorax. Then you go on this CT at each, this is the chest tube, and this is the blood around it, and this is the pneumothorax. لاحظت يا جماعه انه اليوجوال بريزنتيشن بيكون حاصل لانه في سمول نيوموثوركس كده. لو كان في لارج نيوموثوركس اللنج بتكون بعيده منك والله مش كده؟ وانك تكون انت قاصده بس تمشي عليها لكن بيكون away from you. This is chest tube. And this is the pneumothorax. This is the pneumothorax, and this is subcutaneous. This is chest tube around it is a hematoma. Again, chest tube. So how do you manage? And I will say this very quickly. أول حاجة, if the longer the tube is in the lung parenchyma, the likely possibility that it will create a bronchopleural fistula. كل ما قعدت كثير كل ما إنه eventually you will develop bronch. So you have to remove it as quick as possible. في two scenarios. السيناريو الأول إنه البيشنت أصلا كان عنده pathology and the tube was put in a wrong position. كان عنده pneumothorax ولا عنده pleural effusion وأنت دخلت اللنج التيوب دي في اللنج بارينكايما والبلورال فيوجن موجود. So what you do, you introduce another tube. المره دي طبعا ما بتدخلها هنا في بارينكايما، بتدخلها هنا في الحته فيها فيوجن او الحته فيها نيوموثوركس. Once you secure a second tube and it is swinging, then you remove the first tube. After you consult a thoracic surgeon. لأنه مرات بيجيك بلاد والله طالع طوالي معاه. كده. Once you remove you may get blood. طيب ده سيناريو سهل والله مش كده؟ إنه الباثولوجي موجود عشان كده you can easily reduce the second tube. لكن يجي مرات أنت بتكون التيوب في الأذر الهيلثي سايد. How would you introduce the second tube؟ لأنه ما في air ولا في pleural effusion مش كده؟ So this has to be done by thoracoscopy والله. You have to do this by thoracoscopy. The thoracoscopy بتحط tube. الغرض من كده كله شنو؟ إنه يحصل لك tension pneumothorax. So you want to make sure that the first damaging tube does not cause tension pneumothorax. So you have to have secure another tube. And this is the only way. You ask a thoracic surgeon is to introduce a second tube by a thoracoscopy. الثوراسكوبي طبعا بيسهل بيدخل التيوب. And once you secure the second tube, then you remove the first tube. لو خليتها يومين ثلاثة يوم 48 72 hours, you will end with the procedural fistula. طيب. الميديستاينال تيوب placement report طبعا. This is in the mediastinum. This is in the mediastinum, anterior mediastinum. طبعا لو هبشت ال great vessels it will cause sudden death. This is شنو؟ Mubarak. And this is subcutaneous emphysema. And this is pneumomediastinum. طيب ده تيوب اوتسايد كله اكسترا ثوراسيك اللي هي دي ده التيب بتاعتها اصلا ما دخلت هنا كله جوه البلورال كابيل. This is extra thoracic chest tube malposition. This is برضه extra. This is the tube. The tube جايه كده. ده pneumothorax وده subcutaneous emphysema. دي الاوبننج اللي قاعده لنا برا. This will cause continuous opening. المفروض تكون كلها انت you have to observe اخر واحده جوا الثوراسيك كابيل. طبعا يا جماعه دي تشيست تيوب بيكون فيها كده فتحه مش كده هنا وهنا عشان to make facilitate the drainage of whatever fluid ولا دي فتحه قاعده برا مش كده؟ اهو تعالى الليكشر والله قربت اخلصها. طيب دي يا جماعه دي تشيست تيوب واقعه بس لحد هنا واقفه هنا اصلا ما دخلت جوه الكبد السهم ضيق. This is kinked. ده تيوب جايه كده وعملت شنو؟ kinked ها kinking. This will immediately stop swinging. طيب دي برضه outside ها. abdominal طبعا abdominal placement واحنا we have seen this in this hospital والله ها. It either goes to the لو في left side it can go through the spleen وفي right side it can go to the liver مش كده؟ and we have عندنا كيس قبل كده liver spleen sometimes the stomach. You can read about this as a splenic injury. And I will just go to the liver injury لأنه we have an experience with the liver injury. This طبعا goes طلعت من السبلين وماشي طوالي على الليفر. طيب this is what you get if you get get the intercostal chest tube in the liver. You just get blocked. Massive bleeding. This is chest tube inside the liver. This is chest tube inside the liver. طيب يا جماعه في الليفر this what السيناريو اللي حصل عندنا البيشنت فعلا they drained the blood all through. وكان البيشنت هي female and she was hemodynamically stable. So you go for conservative treatment. عملنا سي تي سكان طبعا we make sure that انه ما في biliary injury ولا في portal structure injury ولا في hepatic vein injury. So these are all intact. So we decided to treat her conservative. So conservative جماعة شنو؟ You clamp the tube immediately. You clamp the tube طلع من الليفر. And then you remove the tube every day by 2 centimeters. You remove the tube by 2 centimeters. Unfortunately enough انه طبعا اخطر يوم اللي مطلع التيوب مش كده؟ You expect انه يديك blood كده. It's not unusual والله يا جماعه انه تلقى لك tube in the liver. But you have to know how to manage مش كده؟ ما في procedure اصلا في الميديسن دي اللي accept with the complications, especially if it is put by somebody who is not well trained. عشان كده يا جماعه التريننج ده مهم مش كده؟ التريننج انك انت for the procedure you have to observe well trained. You will do the procedure in front of you. Then you read about the procedure. And then you do the procedure supervised. يعني كل procedure عندها كم مرة you have to be supervised. طيب if you go through these stages وحصل لك complications وما عندك ذنب مش كده؟ خلاص حصل اي زول يحصل له complications. لكن كمان تكون خطيرة لين if you are not supervised والله. بقول يا جماعة if you go outside السودان ومشيت أي دولة وأنت you don't know the procedure you say أنا I don't know. And then they will teach you. لأنه they care about their patients. يعني ما تعمل فيها أنت. في ناس يكتبوا في السي في بتاعهم إنه عمل كده عمل كده عمل كده. لما يجي البراكتيكال ايشو they fail to do this والله. عشان كده لازم الواحد يتأكد إنه هو he knows the procedure very well and he knows the complications ويعرف لما تحصل complications what to do. مش كده؟ لكن don't say إنك أنت you know a procedure وأنت you don't know والله. لو عملت كده you are risking yourself والله. أنت دخلت في مشكلة. Sometimes they polite. For patients with a resultant major hepatic hemorrhage, vascular injury, and or they have to go to surgery immediately. There is no other solution. This is the last part of the lecture. Removal of the chest tube. The timing of vein removal is dependent on the original reason for insertion and clinical progress. It depends on the clinical issue. The emphysema, or complicated pulmonary effusion, ولا هيموثوركس ولا ترانزيديت. Sometimes you need for a transitate. تحتاج منه وانت دخلت التشست تيوب لكن when you analyze the field it's a transitate. In case of pneumothorax, the drain should not be removed until it's completely sealed drain. ما تدخل إليه blood tube, so it will organize and it will cause future complications. So don't leave blood inside the pleural. For transitate, it will continue when I transitate, unless you treat the pathology. It will continue draining all through. Don't need to hypoalbuminemia, you have to chest tube, أصلا. لكن once it reach about 100 meters per hour, you remove it. وبعد شوية بعد يومين ثلاثة هيبقى التيوب الثاني unless you treat the heart failure, you treat the heart failure, it will not reaccumulate. With complicated pneumonia effusion, it should drain less than 100 ml per hour. طيب في ناس عملوا استدي كالآتي. طبعا لو عندك complicated pneumonia effusion, the pH of the fluid will be low, the glucose will be low في الافيوجن دي لأن البكتيريا will utilize glucose and it will produce CO2 as a side product and this will drop the pH of the fluid. وال ADH will be very high لأنه it reflects inflammation. طيب في ناس عملوا كالآتي. They continue to drain the fluid لحد ما البيش بتاعته is corrected والجلوكوز بتاعه is corrected. It reflects إنه ما في any more bacteria inside the fluid. أنا أقول الكلام ده تاني. If you have a complicated طبعا يا جماعة complicated pneumonia effusion if you don't treat it goes to emphysema. كده؟ لكن you have to drain before it goes to emphysema. So if you have a complicated pneumonia effusion the complicated معناها البكتيريا has entered into the pleural cavity and then it starts to utilize glucose to survive. So once it utilizes glucose, it will drop the pH and it produces CO2 as a side product. And then the ADH will also goes more than 1,000. And it affects inflammation. So some researchers they continue to drain لحد ما تأكد إن these parameters has been corrected. Indirectly it reflects that the bacteria has خلاص طلعت من جوه الجسم. So you have the two options. هو بيحصل كالآتي. If it is less than 100 ml per hour, you can remove the tube. لكن the best thing إنه to analyze the tube again عشان to make sure that these parameters has been corrected. طبعا في النموذج طبعا سهل مش كده؟ يبقى question would you clamp or you won't clamp والله يا فده برضه controversial issue والله يا في ناس بيفتكروا انك انت you clamp لانه مرات بيكون في small air leak ماشي بالراحه وما هيظهر الا بعد 24 hours عشان ما تدخل التيوب مره ثانيه you wait for 24 hours. في ناس بيفتكروا لا if the lung has expanded the chest X-ray وما في bubbling you remove the tube. في ناس بيقولوا لا مرات بيكون في ليك بسيط ما بيحصل لك طوالي immediately on the X-ray so you clamp for 24 hours and surgeons they like to clamp for 24 hours and then لكن never clamp a bubbling tube. طيب ده نفس الكلام اللي قلته انا bubbling drain should never be clamped. By clamping the chest tube, the other الناس بيقولوا clamp. By clamping the chest drain for several hours, followed by chest radiograph, a minor air leak may be detected, avoiding the need for later chest drain reinsertion. انت طلعتها وبعد 24 ساعة accumulate او دخلها مرة ثانية. طيب الشيست تيوب طبعا لما تطلعها during valgava او during expiration. The chest radiograph 12 to 24 hours after removal is recommended. طيب نيجي لآخر نقطة اللي هي if you have a patient on a mechanical ventilator. برضه في two opinions. في ناس بيقولوا as long as the patient is on a mechanical ventilator, don't remove the tube unless you extubate the patient. طيب في ناس بيقولوا كالآتي إنه once the lung has expanded so there is no bubbling, you remove the tube as early as possible. لأنه this will guard against infection. لأنه فوق البطن طبعا كده. طيب أنا أديكم حل وسط. لو البيشنت يا جماعة على high beep و100% oxygen, there is no way that you can risk it. So you need the tube. لكن لو البيشنت على spontaneous breathing على pressure support والlung has fully expanded, then والlung has fully and there is no bubbling, then you can remove it. So in the extremities, patient on high setting 100% oxygen وعلى beep of 15 وعندي tube. there is no way that you can risk the patient. But if patient has spontaneous breathing, and a pressure support, you can remove the tube like this. And then you follow the patient. You know? Faster than if you are trained to diagnose pneumothorax by ultrasound. Non-invasive procedure. You can do frequent ultrasound and make sure that the air is not reaccumulated. بدل ما تخلي تيوب يعني it's not logic to leave chest tube in a patient who is on a pressure support. He's breathing spontaneous. He's offbeat. There is no indication. So this is the الحل الوسط اللي هو بين leaving the tube till you expect أو removing the tube as early as possible. Thank you very much, everyone. This is the end of لو في الآن الزمن والله انتهى كثير. لو في عنده سؤال أنا أعتقد إحنا we are taking more than needed والله يا دكتورة. يعني الناس من الساعة 9 قاعدة واحدة والله. We have to manipulate شوية التيتشنج. طيب في عنده سؤال ولا حاجة؟ Thank you very much.